Hello, my name is Duncan Shrewsbury. I use he, him pronouns and I am a gay, queer academic GP in Brighton. My working week is split between seeing patients in general practice and supporting the development and delivery of the undergraduate programme for Brighton Sussex Medical School. But more on what I do nowadays later. First, I want to share with you what influenced my journey to where I am now. I came out in my final year of medical school, having had friends struggle with their own journey many years beforehand. It felt like I was rather late to that table, but in all honesty it took me that long to accept that part of myself. I had grown up in a context that repeatedly told me that a queer life was a choice, and a wrong and immoral one at that. I desperately tried to be straight for many years, hurting others and myself in the process. Once I was out of the closet though, I tentatively explored that aspect of myself and was lucky enough to meet a wonderful man who later became my husband. There were at least a couple of readily identifiable times during my foundation years of a doctor where I wondered if a continued career in medicine was for me. I often put it down to my long-standing mental health struggles, but now I recognise it was at least in part due to the way that the system expects people to work beyond what is humanly possible, let alone reasonable. This often is made worse by the way that we speak to and treat each other in healthcare. Eventually though, I found my home in general practice and I've loved it ever since. It hasn't been easy. In my last year of GP training, sadly, my marriage broke down and we separated. I found myself having to move in with my mum and stepdad about 50 miles away, which was not at all how I imagined starting in my 30s. During this time, I kept pressing on with work. I turned up and I put my game face on, and I did what I thought was a reasonable job. Colleagues around me kept asking if I was all right or if I wanted time off. I reassured them that I was fine, but quite simply, I wasn't. I had fallen into that trap of presenteeism, turning up when I ought not to have done, driven in part by my need to have a purpose and still be a doctor, driven in part by my need to have a distraction, to focus on something other than my unravelling life, and also probably driven in part by a lack of insight. I had been becoming increasingly snappy with colleagues, and there were noticeable changes to my practice that strayed from the good medicine I would normally strive for. One momentous day, I found myself stuck mid-consultation. As a result of that, my trainer told me to go home and get well, triggering a cascade of activity, including from the practitioner health programme, to which I'll always be grateful for. I got back on my feet and got back to work. I completed my training and then looked for a new life and adventure, a clean slate. After a couple of false starts to this new beginning, I found myself in Brighton and slowly continued to heal and grow, and in doing so discover and learn to love my queerness. Well, I guess probably central to a lot of who I am is the fact that I'm a doctor, I'm a GP. And the fact that being a GP feels so right for me, I think speaks of other aspects of my personality, such as being interested in people and their stories, their families, all the other intricate connections between the different parts of their life. I'm a very curious person and probably quite a nerd as well, and unapologetically so. And on top of that, there is no escaping the fact that I absolutely love and celebrate the queerness that is central to my authentic self, and probably something that I've only more recently discovered and learnt to love. So alongside that, I also take great pride in the work I do to help and support other people, be that patients, be that colleagues, supporting their personal development or mentoring people who I've not yet previously met. I think some of that stems from the core desire to want to help people, but also I've learned a lot from having made a huge amount of mistakes in my life, and that has helped me in terms of being able to support other people taking a shortcut and learning from my mistakes without having to make them themselves. So queerness, and I think the word queer, has only in recent years become something that I have, I guess, reclaimed is often the term used, or become comfortable with. It is still very much tied up in some of the school playground bullying that is very commonly experienced, and certainly something that featured in my childhood. But now it is an opportunity for me to explore parts of my personality that wouldn't necessarily fit in a conventional conception of masculinity, or necessarily the boundaries of femininity that would normally be considered inappropriate for perhaps a man to explore. And so it's almost a little bit like a passport that allows me to venture into and try different aspects of self. And through that, I have found that I particularly like having sparkly nail varnish. I don't mind a little bit of lipstick, and I do wear heels if I don't have to do too much walking. And that's all stuff that contributes to helping me feel more me. It's difficult to articulate. It's not a comfort, although it is comfortable, but it is almost as if your heart sings because it's right for you. Not always easy, of course. There have been many times, even in Brighton, which is considered a relative safe haven for the queer community, there have been plenty of times when I've used the male toilets whilst wearing heels or sequins, and I've been assaulted, or even just on the street. So it's not always comfortable or safe, but there is that something resonates inside when things feel like they align. And I know that has very much influenced the relationships I form with people and friends. And I know that it has positively influenced both my clinical practice and my academic practice. I bring my authentic self to both. I'll teach in a pair of heels. I will consult in a pair of heels, sometimes a skirt if the weather's right. And I'm always surprised, pleasantly so, by the reception of it. I'd be lying if I didn't say there were times where I was worried, how might this be received? And it's only ever, say, from colleagues that you tend to get comments or looks. Patients generally have always been amazing. I remember one particular consultation, and this was, speaks of a little bit of prejudice on my part. I was intimidated by the man who came into my consultation room, and I thought, oh goodness me. And partway through the consultation he stopped and he said, if you ever need your heels repairing, my son found an amazing cobbler just down the road and round the corner. And it just, that spoke of such acceptance and celebration from somebody that I didn't expect. Constantly teaches me not to prejudge situations or people. And I know that it's been positive for my students as well. Seeing a visibly queer person representing the community within the profession, I think, is really important. When I was growing up, I was told you can't be gay and be a doctor. You can't work in the NHS and be gay. I remember my family's reaction where on Casualty or Holby City there was a character who was a lesbian in there. And so even though I knew from a young age I wanted to be a doctor, and even though I knew from a young age I probably wasn't straight, I also knew that there was an incompatibility there, or at least I grew up thinking there was. And I want to absolutely dispel that for patients, for colleagues, for the 8-year-old me who was growing up thinking, can I be a doctor? So the visibility of my queerness is important to me, and not just because I feel more comfortable in my own skin if I've got a pair of heels on, which I know is a bit of an oxymoron, comfortable heels, but the being authentic and visible, I think, matters in so many different respects to our community, that feels very important to me. The journey to where I am now was quite long and convoluted. After I came out and accepted my homosexuality, I formed a fairly conventional relationship, albeit with a man, and I don't think I changed much as a person, and was probably still quite influenced by some of the lessons I had been taught earlier in life. And although it is sad that our marriage came to an end, these things happen, and we're still friends. We just became people with different needs and going in different directions. And through having a clean slate and starting again, coming to a city I didn't know, hadn't lived in before, didn't know anybody, making friends from scratch, was terrifying, but equally liberating. And I'd say probably some of the biggest influences are aspects of the culture that I was able to see, the visibility of queer culture in Brighton, not just drag, but some of the art and the performances going on in the Fringe Festival, for example, the sheer sort of prevalence and visibility of that makes you more attuned and more sensitive to things that you might have thought of, might be considering. And then friends who were or are incredibly creative and fun, and bring that creativity and fun to aspects of their personality, and in doing so encourage it in others, such as myself. I remember a particular sort of gateway moment. I was given a voucher for a makeup shop, and I went in thinking, I don't even know what on earth I'm trying to pick out here. I just know that I want some sort of lipstick. I didn't realise there were 138 different kinds. And the person in the shop was very, very supportive and gentle, and took me to one side where they had like a sort of setup with a mirror and a chair and everything. She was like, let me show you a few things. And that also, affirming experiences like that where, people show you that it's okay, show you that it's fun, that it's good, that it's acceptable, those sorts of things helped define the path that I'm continuing along, and do continue to do so. That doesn't mean all experiences are like that. There are plenty of times where you go into shops and people look at you askance and a bit like, what on earth is he doing in here? But on the whole, generally, hold on to the positive experiences. I actually came from my mother. My parents were separated and I was the oldest child, so my relationship with my mother was quite strong, and hearing something like that from somebody that I idolised. She was an incredible nurse. She was a nurse in general practice. And I remember, in school holidays when there was no childcare, we would go and we'd sit in the back of reception reading books or something like that, trying to keep out of trouble. So I really, really struggled with the fact that somebody so close to me, but also somebody who's within the profession, was telling me something so strong and so powerfully wrong. And again, being quite candid, my youngest brother came out many years before I did. He's a very strong chap, and my family were very supportive of him, but I know that there were struggles, and my mum in particularly struggled with the notion of having somebody in her house under her roof who was gay. And this was many years before I accepted that within myself and came out, and was probably one of the factors that played into how long it took me to do so. When I was a foundation doctor who was gay and was talking about his husband to other people, just as other people would talk about their spouses or boyfriends or girlfriends. And there were times where I was told you shouldn't say stuff like that. Or, do people like you need chaperones for everything? Or even worse, when working in paediatrics, being told people like me need to be careful around children. And those little quips all speak of a very toxic, inaccurate understanding of what homosexuality and queerness is, somehow conflating it with other things such as paedophilia. As a junior doctor, it was terrifying. It genuinely felt that I was surrounded by people who might genuinely think that about me. I remember changing my appearance. I stopped wearing pink shirts or anything like that. I became quite closed about my personal life. I didn't join in conversations with peers who would be talking about what they did at the weekend or something like that, because I became so fearful that people genuinely held those beliefs, and I didn't want anything to feed those beliefs and make it worse or potentially jeopardize my training. It wasn't until later, and I think I would probably say it wasn't until maybe a bit of sort of maturation on my part, maybe progressing through your training, realizing that these things are inaccurate and untrue and vile, and growing in my own confidence as a clinician, and even as a trainee, recognizing, I know that this is appropriate and acceptable in terms of developing my competence for training and demonstrating that, and that is completely separate from any prejudicial views that somebody may have, and having the confidence to be able to see and articulate that. And so it was probably only in the last couple of years, maybe 2-3 years of my training, where I was probably able to challenge those sorts of things, such as, do people like you need chaperoning for everything? First of all, sorry, what do you mean people like me? Because I just want to be clear what you're talking about there. And second of all, really, we should all be offering patients chaperones for everything, but that's a patient choice. There may be times where you as a clinician pick up on something, a dynamic where you feel, I think a chaperone is appropriate here, but not a blanket ruling based on someone's gender expression or sexuality. I would avoid confrontation at all costs, and anything that feels remotely confrontational sets my heart racing, and I'm all of a quiver. But yes, there are some situations where it presses a button and you think, it's not right for me to let this stand, either for me or for the next person who comes along. And so I should recognise my relative position of privilege and use that and gently correct and challenge that. But yes, those moments can be quite terrifying and require that emotional courage and can be very draining. So speaking up against things that feel particularly prejudicial, I would say probably if it was just something mild and only affecting me, I'd probably let it slide, because pick your battles. But if I thought, gosh, no, this is something quite systemic or structural, this could affect somebody else, or if somebody else came into this role next and they were also gay, but thinking about intersectional disadvantage, if they also had, say, like a disability or were from an ethnic minority background, would their disadvantage be so sort of piled on by these sorts of prejudicial views? So in those sort of contexts, that's often what triggers this can't stand because it can't stand for other people. And sometimes there would be a sort of wider notion of how can we expect society to learn and change if we don't teach it and nurture that? And so sometimes that would also influence my decision to speak up about something. And I tend to try and approach it from a gentle educational perspective. I don't think people are going to learn if they feel threatened. So I would avoid anything that felt confrontational, partly because of my own anxieties around that, but also because I think that that's probably more effective to support learning and change. I loved medical school, and I'm very fond of the memories I have of my medical school, but I don't really recall the health inequalities affecting the LGBT community or other communities, really, marginalised communities being represented in my undergraduate education. In postgraduate education, it was articulated as a curriculum item in terms of the postgraduate curriculum values this, but you've got to go away and do something about it. And there's not necessarily the sort of provision or support for developing skills or knowledge in that area, or at least there wasn't. That was one of the fantastic opportunities that I was given when I started at Brighton Sussex Medical School. I was asked if I would help rewrite the first 2 years of the clinical and community practice strand, and I did. And within that I included a new strand of learning called Inequalities and Inclusion in Healthcare, which focuses on broader subjects around disadvantage and intersectionality, but also spotlights specific inequity faced by certain marginalised communities such as migrant health, LGBT, sexism in medicine, both in terms of from a clinical perspective but also professional. And within those sessions we draw on simple things like role modelling techniques and things like that to help people get a bit more comfortable with the idea of being an active bystander in those sort of situations. What do you do if you see injustice? What do you do if you see something that's just not right? So that people feel better able to support that change, development and learning. So my notion of an active bystander would be somebody who has some sort of allegiance or allyship with the person that they are seeing as a victim in that situation. And after prioritising safety, physical, psychological, all of it for the victim and yourself, choosing to do something to help, something reparative. Now, for that person it might be that they need an escape route, so some kind of distraction or some kind of challenge. Excuse me, I'm sorry, but what I just heard sounded quite racist to me, or something like that. And that puts an absolute full stop and holds a mirror up to the person who's just done or said that thing, and it takes the attention away from the victim and allows for them to escape to the sluice room and have a cry or something like that. Then there are also the other sort of reparative measures that can be taken, such as going up to somebody and saying, I saw this, and to me it felt like that, or sounded like this. Are you okay? Is there anything I can do to help? Or would you like me to do something next time I see that, or something now? Shall we go to your supervisor together to talk about this, and I can support it as a witness? So in my sort of view, thinking of those sort of situations, an active bystander is somebody who would at some point, either during the time or after the fact, provide space for some reparative measures, and using their position of recognised relative privilege to support the voice of the individual who's essentially being victimised or oppressed. Yes, and does being my authentic self make me a better doctor? I guess it depends on what sort of notion of goodness you're thinking of, how you define it, and what kind of metrics you might be concerned with. I know that on the anonymous patient satisfaction questionnaires that we have to do as part of our revalidation, I've had feedback from patients saying, I thought this doctor would be different because of his pink hair, and he was amazing, and that kind of stuff. I also had a patient, an older woman, start talking to me about the fact that she was thinking of training as she was ordained as a Buddhist priest, but training to do ceremonies, it was like wedding ceremonies, because she wanted to support her daughter, and the fact that she chose to open up and speak to me and ask me about that sort of stuff felt like a whole different level of privilege. But I guess also on top of that, being my authentic self, not having to spend energy hiding yourself, feeling like your heart can sing at work too, means that I do think I can bring more energy to what I do in work. I can bring different insights that I don't have to shy away from. I can draw on my experiences to empathise with patients who are going through certain things, or to help reassure them that although I may not necessarily have lived experience of what they're going through, I'm sensitive to what they're going through and can be a partner on that journey with them. That's a good question, and I'm often quite careful in the heat of the moment not to change the dynamics of consultation and make it about me and my experience. But I do think that there is a way of signalling understanding or a certain depth of empathy with someone that indicates to them that you know. And you can do that without necessarily saying, oh gosh, yeah, no, I know exactly what you're going through because this thing happened to me 10 years ago. Because then all of a sudden the spotlight's on you and it's not about you, it's about the patient. And also you may have gone through the same sort of thing, but not exactly the same context. So that doesn't necessarily confer full understanding. So yeah, a tentative indication of a certain depth of empathy, I think. I did my GP training in an area that sort of bridged a sort of semi-urban setting and then also quite a rural setting. And in both situations, I was the only person within the organisations I worked in that was, or that self-identified as being gay. And because of that, I would sometimes get people being referred on to me. I'll go and speak to Duncan about this because he knows about that sort of stuff. My lived experience of being a gay man somehow conferring expertise in all of the above. And I know that there were probably times where I was consulted by people and I probably gave suboptimal responses or information or advice or care. And that's definitely influenced my work, because not only did that prompt me to get better, to know more, and to intentionally study and not rely on my own lived experience, almost not quite discounting my lived experience, but totally deprioritizing it. And that has also massively inspired the work that I do both in undergraduate medical education, but also postgraduate. So I quite regularly find myself running training sessions for GP training schemes or CPD groups and things like that, so that I can share the lessons I've learnt from getting things wrong with people, so that they can hopefully deliver more informed care. I feel very ashamed of this actually. I remember in the rural practice I worked in, I had somebody booked in with me who was outwardly masculine presenting and was assigned male at birth, but came to speak about feelings of identifying as a woman. And now I recognise that by the time somebody's plucked up the courage to speak to a complete stranger about this, they've usually thought and felt about it for a very long time and usually done a lot of reading and just need your unconditional support and understanding. And in this person's situation, they discussed or described only feeling it relatively recently for a few months, and not being too sure. And rather than acknowledging and validating that, I suggested that perhaps they weren't too sure yet. Perhaps it might be a thought that hasn't quite matured or might not even necessarily reflect a reality within them. And shamefully, I suggested that they have some more time to think. And in my mind, that translates as me judging that individual as not being trans enough yet. And so I'm quite careful about driving the message that if somebody does come and speak to you as a doctor about their gender identity, they don't need to prove that they are trans enough. They don't need to prove that they've suffered or thought about it enough. Just validate and acknowledge that thought, that experience, that feeling, and support them without challenging it or questioning it. That's based on judgment, and that's not our job in healthcare. Our job is to support, not to judge. I mentioned earlier on about being careful not to change the dynamics of a consultation and make it all about me. I was consulted by a young man who had come out to his family as gay, and was told to leave. And he was staying with a friend on their sofa. He was essentially sofa surfing, and he was below the age of 18. And so there were a few different considerations there, and in trying to ascertain how he felt about himself and thinking about risk stratification and mental health, I brought my own experience into the consultation, and I felt that it may very well have indicated to him that yes, I'm also gay and I have some degree of understanding. I wasn't forced out of my home. I was much older than he was when I came out. I had totally different things and demons to battle with. And I think that prevented me from being able to get a deeper understanding of what he was going through, because I think introducing bits about my experience changed the dynamic of that consultation. And so it's a skill, and there's a subtlety to communicating with people and alluding to or indicating understanding, or as I've said before, a depth of empathy. I think listening in a way that resists giving anything other than nurturing feedback. Carry on telling me more, or goodness, yeah. Rather than trying to direct the rest of the conversation in a way that you think it needs to go. Like, I need to know, are you having any suicidal thoughts, or are you self-harming? Wait a bit, give them the time and the space. They will explore it. So, first and foremost, I found myself a fantastic therapist. and it's expensive, but it's an investment. And I have therapy at least fortnightly, sometimes weekly, depending on how busy our schedules are respectively. And that's taught me a lot about myself, but also the reflective space that provides. Sometimes my therapist will say, do you think this is pressing some buttons for you? Or something equivalent to that. And I really do advocate that everybody in the helping professions should have access to a decent therapist, and it shouldn't be limited to just 6 or 12 sessions. I think some people do benefit from having an ongoing longitudinal relationship with somebody with those skills. The practitioner health programme started off as a scheme within sort of the Greater London area for GPs, I think, or doctors possibly more generally, but specific within that region, who had difficulties with mental health or with substance misuse. There's a greater prevalence of that within our profession too. And I think around about 2017, Claire Gerarda's programme was expanded beyond the London area for GPs and GP trainees, and I think that was in recognition of part of the workforce crisis and the pressures faced in primary care. And the timing couldn't have been more perfect, because of course that's when I became unwell again, and it was my trainer who was aware of the service who said, look, being a GP for another GP is really difficult and sometimes requires a bit of extra skill. This lot have those skills, maybe self-refer to them. And I did, and it's a dedicated service, largely run by GPs with a special interest or with additional training around mental health, but also practitioner health. There's a very specific skill set involved in that. But as part of their wider team, they also have psychiatrists from different ranges of specific disciplines within psychiatry, psychologists and different kinds of therapists. And they are there to essentially give unconditional care to people within the helping profession who encounter struggles. So yeah, and it's now expanded, so it's now it's nationwide, and I think it's for any doctor in any grade of training that is able to self-refer to that service. And I would say have a low threshold. If you're thinking about it, go for it. They can always do an assessment and say, this is the level of support that you need, or goodness no, this is the level of support that you need. So yeah, I would always encourage people to at least take a look at their website, or consider filling in a self-referral form or calling one of their telephone numbers if anybody was experiencing difficulty. So picking up on mental health first, my advice to colleagues, looking out for their peers, their colleagues, their friends. Think about how you phrase your questions, how you ask if somebody is all right. Are you all right? Yeah, I'm fine. It's a very easy response. I'm worried because I've noticed some changes that make me think that you're not all right at the moment. Can we talk? It's a very different question. It's still a question that people might say, oh no, I'm fine, I don't need to talk to. And sometimes that might indicate that, give them a bit of space. Sometimes it might indicate that they don't have insight. And if there are more than one of you thinking, I care about this person and I am worried about them, in a loving, not a confrontational way, there is a different conversation to be had about, you're a fantastic doctor and we love and care about you deeply, but something seems to be amiss at the moment and I don't think that you're okay, and I think we need to do something about that to get you better. And having that confidence to say, I know you're saying everything's fine, but it isn't. I would also say, whilst somebody is off recovering, don't forget about them. they still need to feel part of the team. They still need to feel part of the profession, the community. And it can be so easy to get isolated in your recovery. Having time off work for sickness absence plays into all sorts of funny mind tricks. Sometimes you might think, oh, I've got to really look ill, I've got to stay indoors and close all the curtains and, be poorly. But actually that time off is to invest in getting better, and that might mean going out for a walk in the sunshine, having an ice cream on the beach, checking in with some friends, doing things that are going to be paying into your well-being bank account. And I think an important part of that is not necessarily constantly checking in, are you okay, how's your recovery, but hey, I haven't seen you in a while, do you fancy coffee and cake sometime? Or something like that. Something that lets them know that you're still part of their life, even though you've had to take a step back. So that's that for from a mental health perspective, I guess my little pearl of wisdom there, if you'd call it that. But thinking about sort of allyship or active bystandership from the perspective of a queer person, I guess partly celebrating that. I work in a practice where, so there's a colleague who her consultation room is next to me, and if I wear something pink one week, she'll be like, oh, well, I've got to get something pink now. And it's celebrating in it with me, which is very different from conversations I've had with other colleagues in other organisations, where you turn up at the door for your interview and they say, oh gosh, you're not what we were expecting. That's fine. My decision about whether I work with you or not is already made. So celebrating in it with them, and also when you notice that things happen, and they may do, even in the best of sort of situations, things may happen that make you think, gosh, is that prejudicial? Is that discriminatory? Is that somebody mocking that aspect that is fabulous in that person? And doing something about it. And that might be, I'm going to confront that, or it might be, hang on a minute, I think we need to show that this is what our values are and display it. Have a progressive pride flag in your reception area or your consultation room, or say that you want to seek feedback from patients and staff about whether things in your surgery are too pitched at a particular group or not. We often don't think about it, but for example, just the posters in the waiting room, it's usually got a Caucasian nuclear family on it or something like that, that does not necessarily represent the diversity of the community you work in and for. And so just thinking about things like that, and signposting that you're doing so intentionally and why, can be quite powerful. I think my therapist would probably say the lesson that I'm still learning is to be kind to yourself. And sometimes you may have learnt from something that wasn't great in the past, but that doesn't make you a horrible person, and you can let go of it. I still hold quite a lot of guilt about certain things, especially things like the example I gave you earlier on, where I gave what was pretty substandard care to somebody who thought they were trans or was trans. So be kind to yourself and your colleagues and your patients. And, sometimes tensions rise and pots are bubbling over. But Brené Brown often refers to a quote which I think is from Rudyard Kipling, which is something along the lines of, assume everybody's doing the best they can, it makes your life a lot easier. And reminding myself of that is is quite powerful, because somebody may be responding in a way that you think, oh goodness, where's this coming from? But actually thinking, where is this coming from, can help you. It helps you reframe it. It's not a personal attack at me. This is coming from something else here. And sometimes it's appropriate to help them realise that and see that connection too. So I guess that's one big lesson. Another lesson is we are so complex and messy as a species. Is there a fix for things that go off-piste or wrong in our lives? And I think I would probably say no, and some people might say you can't fix something that isn't broken. I'm not broken as a person, I'm just complicated. But there are times, and there have been times in my life, where I have felt very broken. And so for me, I think it's okay to draw on that terminology, but I think it's also important to simultaneously recognise that you can work with that, but it will always be there. And that almost requires a little bit of sort of respect. You've got to keep on looking back to it, recognising that, yeah, we've worked on that and we're better now, but that is still there, and that can still be pressing some buttons. And to keep that in mind and develop that awareness so that you can look after yourself if it does start rising to the surface again. You can be gay and you can be a doctor, you can be queer and you can be a doctor, you can be trans and be a doctor, you can be fabulous and be a doctor, and actually bringing that to your professional work is a strength and is something to be celebrated. And not in a twee tokenistic way, but in a real authentic way, recognising that you as a person are fabulous, and bringing that to the way you understand patients and the way you interact with them and the way that you work with communities is fabulous. Some other points, some headlines from what I've shared, I think is really understanding the fact that we are fallible as a species. We get things wrong, but also we have things got wrong to us, if that makes sense. And in recognising that, sometimes we need a reflective space to pause and think about how that's affecting us. And something that's definitely key from my journey is having people around you who know you, who love you, who celebrate you, but also who can push back when they know you're not fine. So after sharing some of my story, it brings to mind 3 questions. First, what is it that brings you joy about what you do, professionally, personally? Whatever it is, find it and value it, prioritise it. If you don't make time to do it, why? What is it that's preventing you? And what is the impact of that on you? Another point is, how will your journey affect your practice with patients or students? And definitely something I've learned along the way is bringing an authenticity from your lived experience, but without necessarily your lived experience overshadowing the contribution from others. And then finally, how will you cultivate an awareness or self-awareness of what you need? And that can be a physiological need, a psychological need, a learning need. But tune in to your needs and again, value and prioritise them, listen to them and trust your gut.
Thank you for watching this Meaningful Conversations episode. We hope you enjoyed it. If you would like to see more videos in this series, then please like and subscribe to this channel and hit the bell so you can get notified of new videos as they're posted. We look forward to seeing you in the next one.